So I wanted to share with you all some of what we've been doing at Creighton in the School of Medicine, and because I think that it can apply universally across healthcare and healthcare education, because from what I understand, many of you, if not all of you, are involved in education in some shape or form, and you have an interest in humanities and ethics, which is wonderful. So I would love to answer questions about some of what we've been doing at Creighton to see if this is something that you might be able to incorporate in your own school, or to hear from some of you what you're already doing. So at Creighton, we ground all of our curriculum, or most of our curriculum, in the Jesuit educational tradition, which is in Ignatian pedagogy. So when I started working at Creighton about 4 years ago, I didn't really know what Ignatian pedagogy was, but fortunately, it lends itself almost perfectly to the medical humanities. So my background is in medical humanities. I have a PhD in medical humanities from the program down at UT Galveston that some of you might know about, where we learned that the medical humanities were about character formation, reflection, action in the world. And really the medical humanities developed around the same time that St. Ignatius was creating his kind of pedagogical intention for universities. So they really lend themselves nicely to each other. So in the Jesuit tradition, students might start in contexts like healthcare, have an experience in healthcare, maybe see patients, reflect, how does that change my action? And then evaluating my action, and then reapproaching the context in a different way. So the fortunate thing at Creighton is that they have asked me, and so like the dean of the medical school is very committed to the humanities, the president of the university, like this is unheard of. Most of my colleagues and friends are kind of like begging leadership to bring humanities into their curriculum. And I was just in a situation where they said, hey, can you do more of this for us? And at the same time, we were undergoing a curriculum revision at the exact same time. So we have changed our curriculum to what we call the New Era curriculum: experience, reflection, action. There you go. There's the Jesuit tradition again. And what that looks like is that this is year one, for example. And the blue track is kind of these traditional things that you see in medical school. Foundational science, blood and lymph, neuroscience, cardio, respiratory. But then we've got the gold track, which is personal and professional development, and that's where medical humanities lives, and leadership, and healthcare delivery systems, and research. And really we see this as kind of like the cultivation of the physician as a person. And then below that, we've got the green track, which is clinical skills. So teaching them doctoring and listening to the heart. And so learning those skills that they need to encounter patients. These are all blended together. So if I'm in my cardiovascular course in April, I'm obviously learning a workup of listening to the heart and what are heart murmurs and heart sounds. And then at the same time, I might be on an ethics course about when do you turn off a pacemaker at the end of life. So we try to incorporate all of this together, integrated, so that a student just kind of, oh, this is part of becoming a doctor. I need to ask myself these hard questions. So these are our gold track disciplines, and then the folks that we have identified to kind of lead the charge. So the gold track is not just ethics and humanities, although you see those. And this is my colleague, Kevin Fitzgerald. And then we've got personal and professional development, leadership, patient safety, et cetera. So this is all the elements of the gold track running through the whole curriculum. So I want to focus on the humanities and ethics curriculum because I think perhaps this is what most of you are interested in, and how we developed that. So in this curriculum, we have mandatory small group sessions that all students have to participate in. And Gail is actually one of our small group leaders, and we're very grateful for that. So all first and second years participate. There's 13 sessions of either ethics or humanities in the first year, 10 in the second year. Then we have developed what we call student interest selectives. These are like 5-week courses that we do in a seminar style, almost like a graduate course. kind of a deep dive into the humanities. So all students have to complete at least one of these before their third year begins. And we have this really cool collaboration where we've got professors from the College of Arts and Sciences, maybe in history or philosophy or anthropology, who develop these courses that the students take. Some of the examples of the courses we have are the history of disability in science and medicine, creative writing in medicine, learning from the dying, is race real, racialization in science and medicine, narratives of neurodiversity, Death, Health, and Dickens. So reading some of Charles Dickens' works and seeing like, can we extrapolate what was happening in that time to some of the same questions we're still dealing with. And then we love this course, The Art of Examination, How Observation Leads to Empathy in Healthcare. And this is taught by one of our faculty who has an MFA, and students are actually painting and drawing and learning how to see differently. The students love that course. So when we were developing all this, we really had to step back and ask ourselves, why the humanities? Why do the humanities even matter? So what is our intention with them? And I think this is so important for people to ask when they're thinking about developing humanities curriculum. This is a big question actually in the medical humanities right now. Like, what are we doing? What is our pedagogy? What are our intentions? Is it just like a nice thing to do for students, or do we have like a real theoretical grounding here? So we ask ourselves, what is our intent? What do we want to cultivate within our students? Is it empathy? What is empathy? Is it just to be nice? What is it that we actually want to do? And how do we do this? So when I think about the medical or health humanities, I usually describe it this way, and you can definitely disagree with me because this is the definition that I have come up with personally for myself and for my own teaching philosophy. So I see it as a field that gathers together the insights of a lot of disciplines. So it could be literature, history, art, gender studies, anthropology, to foster a richer understanding of the human experience of injury or illness, or disability and ability and identity and gender and embodiment, and of the healthcare system. So getting that wisdom from all of those disciplines to foster a richer understanding. And to me, the health humanities emphasizes or underscores the fact that medicine and all of healthcare is laden with existential questions about the meaning of life and death, that medical practice is inherently interpersonal, whether that's patient to practitioner or practitioner to practitioner or practitioner to self. And that illness and suffering are about more than the pathophysiology and the biology of the body. Patients are much more than their injury or their illness. So the moral imagination to me is really important. So a lot of people will use this to describe what empathy is. I like the moral imagination a bit more than empathy because it can be kind of elusive and hard to grab. So in my mind, the medical humanities give students both the emotional and the cognitive or intellectual capacity to imagine something of what it might be like to be the person in front of me. Not I know this person and I know everything and I'm going to assume that I know who you are and what you need, but it fosters that emotional and intellectual ability to imagine something. So Martha Nussbaum says in her book, Cultivating Humanity, compassion requires a sense of one's own vulnerability to misfortune. To respond with compassion, I must be willing to entertain the thought that this suffering person might be me. And this I will be unlikely to do if I'm convinced that I am above the ordinary lot and no ill can befall me. This really drives a lot of the way I create curriculum, that I want students to go, what would it be like to have a debilitating stroke and my entire identity change? What would it be like to get a terrible cancer diagnosis or a traumatic brain injury? So in my mind, what students need is time to consider who they're becoming and who they want to be. What kind of PT do I want to be in the world? An understanding of the lived experience of illness, of suffering, of loss, of death. A critical understanding of the socio-political conditions that shape medicine and shape patients' experiences. And a contemplative, reflective, intentional curriculum that acknowledges that our students are whole people who are being formed during their educational experience. So questions I think that our students should be asking is, what is it like to be sick or injured? What's it like to get a terrible diagnosis? What does it mean to suffer beyond my body, emotionally and spiritually? What are the social, political, cultural, racial, class conditions that contribute to health and illness? Why do I feel called to healthcare in the first place? And what makes healthcare meaningful? Okay, here's the $1 million question. How do we teach this? Can we teach this? I ask myself this a lot. So slow medical education came out in 2015 when there was like the slow food movement and all of those slow movements. So Denise Ware and her colleagues, Delise Ware, writes about slow medical education. And it's this idea that it should be discussion-based as opposed to just like memorizing and regurgitating information that our medical students are so prone to doing. Informal or written dialogical reflections. This is why we do small groups. And this is why we have our students write a reflection before they get to small group. In medical school, they're doing a lot of writing. They probably really resent us, but we think it's good for them. There's a personal emphasis on mentoring and feedback. This is why we believe in having faculty facilitated small groups and that those faculty write feedback to the students intentionally. Let's see. So our second step was to identify best practices. And you all can do this too in seeing like what other universities are doing. So I saw Penn State's College of Medicine. So Penn State and Hershey had the first Department of Medical Humanities in 1967 and hired an English professor back in the 60s to start teaching medical students. So in the first 2 years, this school has decided that they will meet every Tuesday morning for 2 hours. So they've got a large group session, and then the second hour is a faculty facilitated small group session. For the first 2 years, every Tuesday. So this is what their curriculum looks like. You won't be able to see what all of this is, but what I want you to pay attention to is all of the orange is medical humanities. Anywhere you see orange. It goes through their entire curriculum. And it's every Tuesday. So if my students complain that it's too much, I'll be like, oh, you should have gone to Penn State College of Medicine. You would have had it every single week. So step 3 for me was to collaborate with the ethics curriculum and my ethics colleague. We did not want to be redundant. We wanted to be synergistic in some ways. I give him leeway. He does whatever he wants for the ethics cases, but we both know what we're doing. And so we know the right and the left hand know what's going on. So we decided to use the same small groups and faculty facilitators. Even though it's different content, we kept it consistent for the students so they knew that where they show up, I mean, right now they're all online together, but they would theoretically know where to show up and who's in their group, and that we both have an emphasis on reflection. So we intended to make both the humanities and the ethics content relevant to that blue track I showed you. How do we make it relevant to pulmonary? How do we make it relevant to neuroscience? That to me is the hardest part. But we have really tried to make an effort to do this so that the students go, oh, this matters. This is relevant to becoming a doctor. So, you know, we try to make it work. Here's our attempt to sort of make it work. There's a lot of moving parts, but you can see that in immunology, for example, my colleague has done vaccines because that kind of makes sense in that block. And then in the MSK and head and neck, I start asking students like, what is medicine? They're doing a lot of anatomy during that block, but I want them to go, wait, is there more to medicine than just looking at the path, the physiology of this body? So we tried to be intentional about all of that and coordinate it, but it's a lot. It's a lot of moving parts for that. So I want to give you an example of what we did, and then I will stop talking, of what we did actually in the neuroscience block. So I wanted to focus on illness, injury, suffering, and identity. This was, what is the lived experience of suffering and illness? So we had students read a small section of When Breath Becomes Air. If you haven't read it, I highly recommend it. I see some heads nodding that you have read this. Wonderful book, heartbreaking, but this is a neurosurgeon who at 36 gets diagnosed with metastatic lung cancer, even though he's not a smoker or anything like that. And his experience of being a neurosurgery resident who's dying of cancer. He really kind of captures that change in role and identity that happens with that diagnosis. So because this occurs in the neuroscience block, and hopefully Gail thought that this session was an okay session because it's really her wheelhouse. Thank you for the thumbs up, Gail. I wanted the students to think about what is it like to live with a brain injury. The medical students often will see the acute phase of these injuries, discharge a patient, and then never ever see them again. Not knowing that PT, OT, speech, respiratory are really the work that these patients are enduring and going through. So this is a really great series. It's a 4-part series on YouTube of what it's like to live with a brain injury. This is in New Zealand. They have this amazing interprofessional residential live-in place where these patients are getting so much therapy. And then there's this kid that's like their age who gets in a motor vehicle accident and is a totally different person. And so we watch this in the small group and then talk about it and reflect on it. So Gail, I will say I had a student email me last week and say, hey, I kind of remembered those videos we watched last year. Can you tell me what they were? I have a suggestion. I just think I left feeling grief and it wasn't very hopeful. And maybe we could replace it with some more hopeful videos. I'm like, oh, wait, that's not what we're trying to do here. This isn't about medicine fixing and then suddenly these people are back to normal. So I'm glad that it sat with her. I don't want to torment the students. I don't want to make them suffer and grieve. I want them to be in a place where they can reflect on this. But that's exactly the point, that medicine is not here to just fix and cure, which all of you are so good at knowing that there's so much work that goes into healing. But we're trying to get our medical students to see that there's a huge picture in medicine and that they need their colleagues like you all to take care of patients. And then the last thing I will talk about is we did add this article in here because remember how I said the medical humanities should talk about the socio-political concerns? This article showed that 72% of the homeless population or persons who are currently unhoused or experiencing homelessness have a brain injury. Whether the brain injury has led to the inability to keep a job, or if they get the brain injury after they are experiencing homelessness, the fact that it is that high, I hope helps my students to see, wow, a diagnosis or an injury has these ramifications that are abundant. And especially in a country where we might not have the safety net to care well for these people, that as physicians, future physicians, they should care about these socio-political issues as well. And I was hoping that it would drive it home to them that this health-related issue is completely related to the way that these people have to live their lives and their access to economic security. So I think that one of our issues that has really limited some of these things for us, because there are things that have gone really well. Like I mentioned, total support from administration, leadership, students were pretty open to it. And we had this new medical curriculum. But some things that went not so great and are a consistent challenge for us, and what I want to hear from you all is that, okay, time is always an issue. We have to kind of measure ourselves with the amount of work students are getting in their didactic blue real curriculum, as they might think of it. Budget is an issue. We had bureaucratic hurdles of how do we pay arts and sciences faculty with School of Medicine dollars. We could not figure it out for the life of us. We eventually did, but it was way more difficult than it should be. Distance, me creating this curriculum in Phoenix while my colleagues were in Omaha was pretty challenging. Now with COVID-19, it has to be online, and this is not intended to be online. This is intended for personal connection. And finally, for us, it's board exams. From what I could tell, that's my dog barking. From what I could tell, you all have boards, your students have boards after they graduate. And please correct me if I'm wrong, but it looks to me that they do. Our students have at least 2 board exams while they're still medical students and can't advance to the next year without passing them. So when students say, I got to get tested on this, and your humanities fluff is not on that exam, it's a hard sell, right? And they want to focus, and rightly so. We've created a really problematic system in medical education where these boards determine their fate in a really inappropriate way. And if I was in that system, I'd focus on the board exams too. But until we change this, this is going to always already be a problem for our humanities scholars. And I don't know if your students too feel like they need to focus on that part of their curriculum that's going to prepare them for boards after they graduate. So I'd love to hear your experience. So I'm going to stop sharing this, and I would love to hear from all of you if any of this resonates with you, or if this is totally off the mark in terms of medical education. I had on my calendar to meet with a PT colleague that I have in Boston to say, hey, what could I add to this talk? When the talk was in November. So I'll tell him our meeting is canceled, but I would love to hear from you all about your experience, or answer any questions you have about our curriculum as well.
Nicole, I have a question. First of all, I really appreciate what you're doing, and it sounds so interesting. Do you have any outcome measures, or do you track the effect of integrating humanities into the program? And what do you measure, and how do you measure?
Oh, Bruce. Okay. So Gail's giggling a little over there. We are on a research team. We have an internal grant right now to kind of look at what we're doing. Do we have outcome measures? So in some ways, outcome measures are like anathema to me, because I'm like, oh, it's the humanities. There's nothing to measure. We're just creating good people. But I get it, right? Like, we need to see what we're doing. So it is a qualitative study, Bruce, and we are trying to ask that very question. We went around and around and around to say, what are we measuring? Is it empathy? Do we use the Jefferson scale of empathy? Or what we're trying to do is say, do these students get it? Do you know what I mean when I say that? Like, when you've got your PT student, you're like, oh, they get it. They're going to be great. That's what we're trying to measure. So we've had to put parameters and words around it. So what are we doing? The first year students have to write a final ethics and humanities paper where they reflect back on the year. Gail and I personally went through those essays because that's part of our qualitative data. We're going to be doing interviews, end of year surveys. And one thing that we snuck in there, which we think is kind of cool, is that their end of the year survey, we put in a question that does not seem like a research question. Please describe the patient population you take care of. And we're able to compare these students who are in the ethics and humanities new curriculum with the ones who are in the old curriculum, because we are rolling this curriculum out stepwise. So you had these second year students who are in this old curriculum, legacy curriculum, and then these new students in this new curriculum. Do they answer that question differently? Do these students in the first year say, I've got patients who really struggle because they don't have access to healthcare? Or do I have these patients who are non-compliant and keep coming back and don't let? So we're able to kind of look at how they answer that question. And then the quantitative measures we put in there, because we know a big journal is not going to take our just qualitative stuff, is the Jefferson Empathy Scale, comparing the classes. We want to extend it longitudinally. So do they lose this when they enter their clinical years? The Intellectual Humility Scale, which can measure, oh, can I learn something from my patients? My patients are teachers, not I'm here to give all of my knowledge to my patients. And then the Social Desirability Scale, are they answering these questions just to be seen in a specific kind of way? So we chose mixed methods to try to see if we're doing anything, Bruce. And, you know, it kind of keeps me up at night because I still wonder what we're measuring, but we're trying. So we're just collecting that data now. Some of what we're seeing in those essays that Gail and I were analyzing is a different perspective of medicine, that medicine is not just fixing and curing. We're seeing a little bit of an understanding of existential suffering, but that was a assignment. They knew what to write for that. So that's why we're trying to get data from all over.
Good.
Nicole, I'm looking for an article. I think there's opportunity to connect the dots here. Some of us, the movement of competency-based education and the decision about supervision, the EPAs, the entrustable professional activity, and Ola Tenkate and Carrie Chen, who's at Georgetown, pediatrician, they just came out with a paper, which I'll send to you, on the ingredients of a rich entrustment decision. And it's all about trust. Yeah. It's all about these humanities. It's all about, because they got another paper coming out on Miller's Triangle where they put trust at the top. And that's the humanities. I mean, whether you can trust a student to do something has everything to do with their being.
You're right. You're absolutely right. And that's do they get it? Can I trust them?
Yes.
Yeah, I think that's right. And to Claire's point, we need to integrate this because 30 years later, my colleagues still struggle with keeping reflection as practice as clinicians. Yes. Doesn't it just seem like the medical humanities were developed in the 60s? 40, 50 years later, we're still trying to do the same stuff over and over and over and over again. Maybe we're doing something wrong. And yes, Sarah, thank you. Jefferson's scale of empathy, the intellectual humility scale, and social desirability for our question up there. Thanks, James. Great. Yeah, so Gail, do send me that article because maybe it is trust.
I'll send you both papers. Yeah. I'll send them to Cindy too to send out to the folks. Yeah. I just think connecting our worlds. Otherwise, we're going to go into this. Here's the skills, here's the knowledge.
Yep.
And we know that that's not necessarily true in the workplace and how things happen.
Absolutely. Absolutely.
I had a question for you, and I think we had a very great talk given by one of our colleagues, Alan Jetty, on population health and making the case that we need to focus, because when you look at the delivery of care, and it's just, it's like less than 50% of, we know it's all wrapped up in the social determinants. He made an argument for the moral determinants, and how we navigate that with students.
Tell me more, moral determinants.
He took some things out of Berwick's article, opinion piece on the moral imagination. Don Berwick wrote a piece, and he pulled from that. I don't know. This was probably for more discussion, but
go ahead, Gail.
Well, I just have the feeling that we're going to swing towards just, it's another new shiny thing. It's very important, but, it's population health, and then how does that fit with, how do we integrate it in a way versus, here's where we're going to focus.
Yes. Gail, I think you're right, because it's so tempting, especially at least with my medical students, that population health just becomes epidemiology. And I need to understand these numbers, and then we'll know what we're doing. So I would think the integration potentially would be the moral determinants with population health has to be narrative. It has to be the story. Here's the zoomed out view. Here's population health, but show me one person who lives in that population and what this experience is like for him or her. That's where, if we zoom out too far, the question, why do I care about population health? Because this person is suffering. And I think we have to zoom in on that. And that's the humanities.
This is Cindy. Hey, thank you. That was a great talk. I'm on the other end of the spectrum, or at least I think I am. So I'm a pediatric therapist. And so there's this lovely diagnosis called cerebral palsy, where a lot of, it's kind of like saying you're having a headache. And unlike population health, at least at the real scientific level, they're starting to begin to go much more individualized, where we're looking for the genetic differences on every child's different cerebral palsy. And I also feel like that may not be the best direction. It's like, it's kind of like, how do we find this balance? Because even if you find the genetic flaw, and it makes Susie different than Cindy,
Yep.
it still doesn't necessarily, at least in today's world where we are with respect to technology and medicine and rehabilitation techniques, it doesn't change those dramatically. So it's like it's just these radical ends. I mean, I'd love to see us come to the middle, and I think that is where humanities is. It brings everyone together, not just the real individualized end or the population end.
Yes, that's right, Cindy. So you're in your world zooming too close, zooming in way too close down to the genetics. And I think on both of those, when we're zoomed out too far, we're zoomed in too much. It's easier to talk about genetics and numbers, and that feels safe to me. But then it's getting back to why. Why does it matter that these genes are different than this? Does it have an appreciable decrease or impact on the way that their lived experiences, on her suffering, on her way of being? And when we lose the why, which we do all the time in healthcare, what's the point of all of this? And my hope is the humanities gets us back to why. Why are we doing this? Why does this matter? Because to me, that's the most important question. Otherwise, we're in the weeds of genes or populations, and we need to get back to why.
Yeah, thank you so much, Nicole. I just always love hearing you speak. It's so inspiring. And yeah, I think that oftentimes when I'm talking about the humanities, being able to say what we do in PT is so much about the how and the what, and the humanities gives us this framework to really know how to ask the why questions, right? And also the who questions.
Mm-hmm.
And so who is that person? What gives their life
Yes.
meaning behind those functional goals? And
Yes.
And then why does that really matter? So and recognizing, I think, I mean, you make some great points about some of those challenges, I think, behind financial support and vision for a program, and then just the realistic sort of demands of a healthcare system that makes folks have to take exams and learn the core concepts. But it's, I think, coming back to there's also that not only the intent to improve clinical care and your experience as a clinician, but also your own sense of well-being and purpose, and giving and reminding folks of you don't put your life so much. We all put our lives on hold when they're in school, and you think you just put off all of these things of our sense of self. And when we have to get through hard times, especially when you think of something like the pandemics that we're going through now, what gives us resilience in part is coming back to meaning. And so it really one thing, just as a question, so there is that dialogue around, do we call it health humanities or medical humanities? And do you mind just talking a little bit more about
Sure.
your thoughts?
Sure. So full disclosure, my diploma says PhD in medical humanities, right? So there's part of me that's like, can we not change this? So that's one element, just because, and I say that as an example. We've tried now for 50 years to get people to understand what medical humanities are, and they're finally kind of figuring it out. So, when my fear is creating confusion with health humanities, even though I have no problem using them interchangeably at all, actually. But this is what I would say. So when there was talk in our world about changing it to health humanities, there were people who felt that when we call it medical humanities, it feels like medicine, and that a nurse doesn't identify as practicing medicine, and maybe an OT or a PT doesn't identify as practicing medicine. In my view, that's a problem. If we cannot widen the tent and say we are all practicing medicine, then that is a serious problem, and that should reflect back on the people in medicine who are being mean and not letting people under the tent. So in some ways, I think it's this a problem with just the nomenclature not feeling like it's inclusive, and we need to work on inclusive. And okay, a PhD in an MD's world, I get it. I get it. Every day I get it. I get that I'm not really part of the group. So I would rather get real self-reflective and start helping people feel like they're practicing medicine than to change the title, because I think it doesn't get to the core issue. So that's just my perspective on it, but I also just embrace using health humanities as well.
I think one of the things that strikes me too, sorry, Bruce, was that within that definition of health humanities, it also brings in the patient and the families and caregivers. So how do you, that, because oftentimes that's kind of what's missing. We're all about ourselves and not coming back to that. So, but I appreciate your point, too. It's, I think where I struggle is as I'm moving forward and we do reviews in the journal, do I push all these authors to use health humanities versus medical humanities? And then as I'm writing about it, how do I use those terms? And so that I can, again, recognize it's not just about writing now, but how does what we're writing now shape the future of the scholarship in rehab science?
I think you're right. And I think that's important. I would probably do the same as the journal editor to use health humanities. I just would, because of the moment in time that we find ourselves. But, to Claire's point about, is it territorial? Yeah, it is. And, those of you on the health humanities listserv, anybody on the health humanities listserv and got to see how territorial things got about, can an MD teach this? Can a PhD teach this? Like, we get turfy, even though we're the people who are trying to be enlightened and ecumenical. So it's like not going away anytime soon. But I think territorial is the right word. So I would say at this moment, Sarah, I would be using health humanities if I were in your position, for sure. For sure it would.
Thanks, Nicole.
Nicole, can I ask a question? And this is something you can't answer now, but maybe next time. There's an emerging movement of technology, particularly telehealth and artificial intelligence, machine learning. Have you thought about where humanities fits in to the use of these types of technology, particularly telehealth? And have you discussed this or reflected on this with your students?
So we haven't talked about it yet with our students, but I think it's really important, especially at this moment with telehealth. I think people intuitively get that they would rather be face-to-face with a patient. And so the humanities really speaks to all that stuff. But then when we zoom out and we go to like population health or something, is telehealth actually the blessing in disguise for patients in rural populations who have a really hard time getting access to healthcare, and now suddenly they can have a specialized neurology appointment because of telehealth? So we've had conversations around this. How do we responsibly use telehealth? And does it actually fix the problem if I then need a healthcare intervention that involves more than just talking on a screen? Well, if I'm in a rural community, I still might have access issues. In terms of AI, I can't go there, Bruce. I cannot. I just feel that, because IBM in 2014 was talking about Watson, if you remember Dr. Watson, which was that you could input all of this data and Dr. Watson would spit out a diagnosis more accurately than your own physician. Yeah. And this was a lovely thing to some.
Yeah, I was thinking of, the human dimensions of care and what you're talking about, recognizing suffering as important in the relationship between the healthcare professionals.
Totally.
One thing I was really surprised to hear, because we had a session a few months ago, Alan Lee is the leader in telehealth, and we had the director of the VA telehealth program. And she said that she is her mindfulness is stronger when she uses telehealth than in person, that she's more connected. And I asked her, why would that be? And she said, because when you're using telehealth, you have to be 100% mindful and focused on the patient and the patient's environment. When you're in person, sometimes you're distracted by other things, or there's another patient. And she felt, and I never thought about it this way, that her mindfulness was enhanced through telehealth. Of course, there were other elements as well, but that was a really surprising statement.
Yeah, Bruce, I heard something similar from my psychiatry colleague she said, my option is to sit with someone masked and I cannot see them emote, or I can see them on Zoom face to face. And for psychiatry, the way someone emotes is like everything. And that she preferred the telehealth for psychiatry, which is, it lends itself, I think, to some areas of healthcare more than others. It would be hard for I don't know. Have some of you done telehealth with patients, and do you show them things to do via Zoom, or go ahead?
So there's a lot of school-based therapists. I'm not a school-based, so public schools have therapists in them. And I'm hearing it from friends and colleagues, strangers and not strangers, that therapists and families, because they've had to go to this telehealth, are really making better connections. And one big reason is therapists who always have brought families into their environment for their meetings are finally getting a glimpse of what home life looks like. And I don't think any of them want to do this 24/7, but I think it's been a ginormous aha, and I think it's been a very meaningful aha, that we get in these little public schools, and probably even in our PT programs, we get in our little bubbles and we don't really remember what's going on outside of those 8 hours, to especially in my world, children. How they live at home has a big impact of how they perform at school. So I think there is a silver lining, although no one wants to stay there forever.
You're absolutely right. And we hear that from our public school teachers as well. Wow, this is what these kids are up against every day to even just show up. And I think that's right. I think getting that glimpse of their lived experience is something we didn't anticipate with all this Zooming. So thank you for that.
I'd like to just add to that if I could. I've been doing home visits for 35 years or 32 years, whatever it is. And it's interesting because I've moved from a home health perspective to a home-based Medicare B. And currently my caseload is mostly orthopedic surgeries, elective, that are just getting opened up again. But I think my perspective as a clinician has always been kind of jaded or guided or whatever by the real life versus the clinic-based perspective of things. And so for me as a clinical instructor, and also as a mom and as a human being who has my own issues, I could be driving to a patient and have a flat tire or whatever. But I need to be, what's the word I really want? There used to be an expression like making space or saving space for someone else's issues and not my own. I could say, I'm sorry, I'm delayed. I had a little car trouble. How's your day been going? And focus the therapy back on them. And I think we kind of forget in the real world, to Bahat's comments before, that, he's got students and they're going through all those wonderful things that happen in your 20s when you're a new grad or new student approaching the field or new to the field or any of those things. And that experience is just as valid. It doesn't mean it belongs to the patient, but it's just as real. And that reflective time that we all need, I think it's slower now that we're in this COVID situation. I think there's a lot more grace period to think, and I hope that folks have taken this time to be able to do that sort of thing. I'm not really sure how that's shaping things if it's not guided.
Yes. Yeah. And Claire, what you said, that this is just as real. What they're going through is just as real as the biomechanics of the body and all of that stuff that feels real and tangible when you're learning is so important, and that we are getting glimpses into what is real for patients. And I don't think we can trade that for anything. So thank you for that. Other thoughts, questions? Do some of you have humanities programming if you're teaching and with your PT students? Yeah, Kay says yes, okay. Humanities, like real humanities? That's awesome. That's so fantastic.
I
Kay,
just
are
had
you?
a wonderful opportunity last summer. The College of St. Scholastica has something they call MOOC, and I told Sarah about it. Did you get to finish any, Sarah? The classes at College of St. Scholastica was online.
Yeah, I thought, yeah, a little bit of it.
Some of it was
really
really amazing. It was really amazing. It was done by the ethics department, but open to all healthcare folks. Actually, I think it would be a benefit to have to anyone, but it was like an add-on thing. And I thought it was very appropriate as a clinician with experience looking for something a little different. But they did. There were 4 different aspects to the classes. I wish I could send the link. They only do it in the summer, but it was free, which was amazing. And I cherished it. There were a lot of TED Talks, a lot of interesting things, but the lead professor was in ethics. And I noticed when I just went through the menu for TED Talks, there really isn't a lot from a PT perspective in this field.
I know.
And I think we need to speak more to the patient's experience, the patient's perspective. Putting ourselves in their shoes is not really always practical, but listening to and listening for the cues to what they're experiencing and what we can and cannot do to help, and how to be the bridge for them to get other services when it appears that those services are less and less available in the real world, like this Zoom stuff. I have a child who struggles with mental health issues, and his physician and he are not connecting because she misses the idioms. It's not her primary language, was not English. And he's 21. And so he speaks a whole different language I don't always understand.
Right.
But it's to be able to feel from his perspective that it's not a connection.
Yeah.
And now going to Zoom, it's just very frustrating for the patient's perspective as well.
Absolutely. And what I always say is that PT, and my best friend is an OT, PT and OT to me so naturally lend themselves to understanding the lived experience of patients. You guys see it all the time, more so than medical students and physicians, at least the hospital-based ones. And I just think the humanities just fit so perfectly with just the everyday experience of PT students and OT students.
There's a wonderful thing out there. I don't know if you guys are familiar with StoryCorps. StoryCorps actually has something on Facebook that is for healthcare only. I just opened it up again and I'd have to look at it, but they talk about things from a hospice perspective, from a palliative care perspective, and they're looking for voices. And I wondered if anything on there would travel well to our group or to our journal. So it would be something to look into, see what was going on. But there was a story of a physician whose patient got onto a Zoom type meeting, and the patient wouldn't make eye contact and was looking aside. And he said to the doctor, in effect, I'm on blood pressure medicine and I'm on sugar medicine, and I need to know from you which one I should afford, which is more important, which one will I die from? I only really have me and the dogs, but right now with what's going on with COVID, with no income, I have to choose one or the other, and I don't know what to do. And he wouldn't even look at the physician. And of course, the call ended and the doc was devastated, thinking about, can I get the maker of the medications to give him some sort of something?
Right.
Is there a way to find a free source? In PT, I'm forever looking for resources. We have a wonderful thing right in town called FODAC. It's the Friends of the Disabled and Children. And they've got resources for equipment things, but they shut down too during this.
Oh.
I mean, There are struggles we all have. We're trying to work at the top of our licensure. All of us are. And to be our most present for our patients.
Yep.
We may not always have an answer, but sometimes people just want to be heard.
Yep.
And that's really what I think this whole humanities is about, letting the story happen.
Claire, I think what you're saying is really important, because it's almost like there's this hierarchy of needs that's becoming very apparent during COVID. And it's like, does this patient need equipment? Does this patient need medication? Does this patient need to be heard? And it's almost like figuring out where to insert that humanistic focus based on this hierarchy of needs. And sometimes being a good humanist is finding them equipment, not listening to their story and putting yourself in their shoes. And, so it's like being able to discern, what can I give of myself here that's most appropriate for this patient is a really important skill, I suppose.
And most helpful, I think,
Yes.
and most helpful. You really have to you have that window of time and you're scheduled and that's it. And you have to be able to say, okay, here's the problems presenting. I can help you with this one. I can't get that one right now, but I heard you and I'm still cogitating over that, and I'll see what I could do to help you.
Yeah, absolutely.
But referring on, I mean, we don't fix everything.
Yep.
Just to add to the whole conversation here too, one of the things that's bugged me for years is that we talk about patient-centered care, but we treat patients like conditions and forget about the patient. And so to me, when you asked me about, or you asked about, do any of us use humanities? If we don't use humanities, then how do we really make the connection for our students about the concept of patient-centered care? And it just, I think we kind of talk out of both sides of our mouth. And I love the structure of your curriculum. We have something somewhat similar, but not as intentional, I think, of getting some of this stuff included in more of our clinical cases, our clinical courses. It's, and when you said that about students saying, oh, I don't have time for your fluff, because I've got to study the other, I get that every single semester in my course evaluations. The students come back and say, I really liked this course. I loved the conversations that we had, but it took away from my time from studying about the things I need to do as a PT. And it's like, okay, I totally failed in my job because they missed the point. They just missed the point. And that's what you asked a minute ago is, do they get it? I think they get it later, but I don't think it's until they're out in clinicals, or even when they're out as practitioners in the first couple of years, because I get that same feedback. Somebody else said it earlier about students coming back later as they've been out and practice in the real world, and they're sort of starting to get jaded by the system. Which brings up that whole idea about the quadruple aim too, the fourth piece about where's the burnout coming from? Well, the burnout, a lot of the burnout comes from the fact that we ignore the humanities, including our own, about how we take care of ourselves as givers, as caregivers and care providers and empathetic practitioners. How do you keep, and that there's the reflection piece. If you don't have reflection as part of who you are. So I don't know, I'm preaching to this choir here, but but that's kind of just, the importance, I think, of including humanities.
Yes.
There's a book called What Doctors Say and What Patients Hear. And we've had our students read excerpts from that as well, to try to help them see the patient's perspective of that whole idea of communication. You might say it, but do they hear it? And do they hear it with the way? And then the other side is, do we listen? We spend so much time talking. Do we really listen? And how do we learn to listen? How do we learn to really authentically hear what our patients are saying to us? So, yeah.
Okay, thank you for that. I think that's absolutely right. And, something that we've been thinking about is, do the medical humanities, health humanities even matter in years 1 and 2? And they do, right? But for our students, clinicals, as you allude to, happen in 3rd and 4th year. If we don't carry this through, it is undermined the minute they show up and they go, oh, this is how you actually do it. You don't actually connect with patients. You don't actually listen to stories. I just got to get through this to-do list as quickly as I can. And then they unlearn it. And then at the same time, when they're years 1 and 2, they don't yet have that clinical experience to go, oh my gosh, I'm glad we're talking about this because I had this patient. So the timing is so hard. And what it means to me is just more humanities all the way through all 4 years for the medical students, because there's never the right time, I suppose. It has to be all the time. And my dream is that I render my job obsolete, that there's no longer a need for a medical humanist, because this is just the way you teach PT/OT students. This is the way you teach medical students, that in their blue track, when they're learning about respiratory and now they're learning about COPD, the physician teaching them is like, and this is what it feels like to have COPD. And this is what I see these patients go through. And these are my group of patients who can't get access to medications, and this is what I have to do. And then I don't have a job. That's what I hope for. That's my dream, to be jobless.
That's not going to happen.
Cindy,
You got job security.
Don't ruin my dream.
Well, I hate to stop the conversation, but we probably need to probably end today. I can't thank you enough, Nicole, for joining us. And we all would love to have one of the things that we talked about in the first hour is maybe doing something quarterly. And you sure, we've never done that before, and you sure would be a welcome guest and a nice kickoff to this new project.
And Nicole, I said a little bit about the degree program, the master's degree and certificate you're working on. So you could update at the next time about the progress on that.
Sure.
Yeah.
I would be happy to. It would be really fun, really fun. I'm glad you all invited me. Sorry I cannot figure out dates, apparently. Because I was wondering, someone had responded back like, hey, Nicole, we really do need your title. And I'm like, but this isn't for another month and a half. But now it makes sense. I think it was Bruce. Bruce was like, we need your title. I'm like, okay.
I had a whole thing written down here. But actually, what I did is when you weren't here, I actually went through it to whet everybody's appetite, and with the idea that we can ask you back anyway.
Yeah.
Just speaking, if I could just say this for the consortium, thank you for doing this. It's a Sunday. I'm sure, you don't have a lot of time off, and maybe Sunday is a day you do. So to give up some of your time really speaks well about your passion and commitment. So thank you.
Yes, and I can't imagine a better way to start a Sunday, honestly. So I'm just grateful y'all invited me. It's going to energize me for the rest of the day. So, because I'm earlier than some of you on the East Coast, still only 9:30 here, so I got a whole day. So thank you so much for inviting me, and I'm happy to come back anytime. So
thank you very much.
Great.
We're going to be doing this tomorrow, so can you come back then?
I'll see you tomorrow.
We'll be in touch, though. Thank you so much.
Thank you.
Nathan's got to go vote, and we need him to go vote.
Yeah.
Go vote.
Go vote, Nathan. Go vote.
All right.
Bye, everyone.
Thank you.
Thanks, everybody. Thank you, Nicole.
Thank you, Nicole.